Hello, good evening, everyone. Welcome to the 2020 CAPER Collaborative Alliance for Pancreatic Education and Research. This is our second webinar, which is out of 5 that we are holding and hosting virtually. And I would start by welcoming you all and our guest speakers of tonight. My name is Dr. Maysam Abu El Haija. I'm an associate professor of pediatrics at the University of Cincinnati College of Medicine, and I'm a pediatric gastroenterologist at Cincinnati Children's Hospital Medical Center. And tonight we're just gonna go over a few housekeeping stuff and then get started with our speakers' talks. So how to ask a question, and definitely this is a format where you would be encouraged and welcome to ask any questions. You can post them through the lectures on the chat bar. Please be aware that all participants can view your questions. And then if you have questions during the Q&A, also you can ask to unmute yourself or raise your hand to ask it live if you wish. I would like to also point to your attention that we have other speakers coming who are great in the pancreatic world. On August 6th, our session is going to focus mostly on pancreas cancer, diagnosis and current treatment, and approaches by Dr. Bahari from the University of Pittsburgh. And that would be followed by pancreatic cancer screening of high-risk individuals by Amy Lucas from Mount Sinai. The following one would be imaging modalities of pancreatic disorders by Dr. Turkis from Indiana University and pancreas cysts by Dr. Shonak Majumder, Mayo Clinic, and that would be August 13th session. And the last but not the least would be on August 20th on overview of acute pancreatitis presentation, diagnosis, severity by Dr. Anna Phillips, and that would be followed by Dr. Catherine Morgan to cover the surgical therapy in pancreatic disorder from MUSC. So I hope you are all excited about the series of the speakers and especially about tonight's speakers. And I have the pleasure of presenting our first speaker, who is Dr. Chris Forsmark, gastroenterologist specializing in pancreatic disease with extensive expertise on the field, and he comes to us from University of Florida to cover a topic of overview of chronic pancreatitis presentation, diagnosis, and course. That would be followed by Dr. Mark Lowe, who would cover pediatric pancreatic disorder, and Dr. Mark Lowe is the professor of pediatric science, the vice chair of pediatrics at the Washington University School of Medicine in St. Louis. So without further ado, I would like to welcome our first speaker, Dr. Chris Forsmark, to share his slides and start his talk. Dr. Forsmark.
Thanks very much, Maysam. Welcome, everybody. Give me just a second to get the... Great. Can everybody see that okay, I hope? Well, welcome. My goal in the next 20 minutes or so is to provide an overview of adult chronic pancreatitis. You're going to hear quite a bit more about pediatric pancreatitis in the next talk. This is just an example of a CAT scan on the left with very dense calcifications in it in a patient with long-standing chronic pancreatitis, and on the right, an endoscopic ultrasound image of a patient with far less advanced chronic pancreatitis. Let's see if I can get the slides to advance. So this is just a sort of a summary of the variety of ways that a patient with chronic pancreatitis might present for evaluation, the common features and some of the complications. Abdominal pain is the most common symptom of chronic pancreatitis. It's the symptom that's most responsible for intervention like hospitalization or endoscopy or surgery, and it's the symptom that most detracts from quality of life. And although it is the most common, it's not universal, so there are rare patients who have minimal or no pain, but it can be quite variable, both in when it starts, what its pattern is, that is it intermittent pain or constant pain or some mix of those two together, how severe it is, how badly it impacts quality of life, and how it evolves over time, whether it gets worse over time or in some patients it actually gets better. The pancreas obviously produces digestive enzymes, and when there's a lack of those digestive enzymes, patients develop exocrine insufficiency. We're thankfully born with a lot more pancreas than we actually need, so you have to lose about 90% of enzyme output before you're not able to digest, at least. So because that degree of damage takes a while to accumulate, that's really a late consequence of chronic pancreatitis, typically 5 to 10 years after disease onset. And similarly, the pancreas has islets which make insulin, and when those are destroyed, patients can develop diabetes. The islets are the most resistant to injury, and so they're sort of the last to go. And this is also a late consequence of chronic pancreatitis, again, after often decades, and it has a particular nomenclature. It's neither type 1 or type 2 diabetes. It's called type 3C diabetes, or also diabetes of the exocrine pancreas, and it's an area of intense research interest these days. And then there are a variety of complications that might need medical therapy. Certainly opioid dependence is a challenge in these folks with chronic pain. They can develop malnutrition and particularly deficiencies of fat-soluble vitamins, in particular vitamin D, leading to osteoporosis. They can develop fluid collections like pseudocysts. They can have vascular complications like thrombosis of the splenic vein or other mesenteric vessels. They can obstruct surrounding organs like the bile duct or the duodenum, and these patients are at increased risk of pancreatic malignancy, as well as small intestinal bacterial overgrowth and gastroparesis. So depending on the patient, they may present with some or all of these features, but these may change over time. Now, it's been said in the past, I think, that almost all patients, adult patients that get chronic pancreatitis, have it as a consequence of chronic alcohol abuse. And that's simply untrue. This is data from a relatively recent study in the United States called the NAPS2 study. And you'll notice that although alcohol accounts overall for about 44% of all patients with chronic pancreatitis, that there are a number of other etiologies that also play a significant role. And I'll draw your attention to the column labeled women, where only about a quarter of all women, adult women with chronic pancreatitis, develop it as a consequence of alcohol. And at the bottom row, you can see that at least in women, the most common explanation is none of the above. It's idiopathic chronic pancreatitis. So many patients of mine that go into emergency rooms with pain flares are automatically accused of being alcoholics, but just to point out that that alcohol is not as common as you might think. And in many of these patients where you presume it's alcohol is the cause, it's actually a combination of smoking and alcohol. Smoking seems to be just about as toxic to the pancreas as is alcohol. And I just want to make one comment, and I think that Mark will probably emphasize this when he talks about pediatrics, and that is that one of the major advances in our understanding of chronic pancreatitis over the last decade or more has been an increased recognition of the number of genes and gene mutations and polymorphisms that can contribute to chronic pancreatitis. There's one gene, the PRS1 gene, which is a very strong mutation that can actually produce chronic pancreatitis in most of the individuals that carry it. So this is the one where you might see multiple family members in one bloodline all getting chronic pancreatitis. But we don't see that too much in adults. It's seen more commonly in kids. What we do see are mixes of mutations and polymorphisms in modifier genes, and I've listed some of them on this slide, like SPINK1 and CFTR and some others. And oftentimes what we find are mixtures of various mutations and polymorphisms that seem to predispose to pancreatitis. And as we learn more about the number of genes that are mutated, the role of genetics in predisposing or causing chronic pancreatitis gets bigger and bigger. And so as we learn more and more about the genes, it also means that we think that alcohol, potentially at least, is a little bit less important as a cause in patients with chronic pancreatitis. So let me turn to diagnosis. Next, I showed you in the first slide that picture of that CAT scan with diffuse calcifications and the endoscopic ultrasound with more subtle changes. We have a variety of diagnostic tests for chronic pancreatitis. Most of them look for abnormalities of the structure of the gland, and those are listed on the left, and I've listed them in approximate order of decreasing sensitivity. And they're things that are familiar, I'm sure, to of you. Histology obviously might be the best diagnostic test, but we rarely have access to tissue in these patients. So we have imaging studies like endoscopic ultrasound or MRI or CT. I included ERCP on the list of tests of structure. It obviously gives great pictures of the pancreatic duct, but it's really never used for diagnosis. It's largely a therapeutic tool. So although it's still on the list, it's not really used for diagnosis these days. And then on the right are some tests that may be less familiar to you, tests which try to identify abnormalities of the function of a diseased pancreas. The one at the top is a hormonal stimulation test, the Secretin or Secretin CCK test, where you give a supraphysiologic dose of a hormone which causes the pancreas to secrete either bicarbonate-rich fluid or enzymes, and then you try to measure that function of the maximally stimulated pancreas. And then a few others that you may be familiar with, probably fecal elastase. Most folks have probably utilized that at one time or another. So how do we think about diagnosis? Well, if you read sort of textbooks or you're doing clinical studies, most of the time the diagnosis of chronic pancreatitis is based on the presence of calcifications. So on the left is just a plain abdominal film which shows calcifications in the pancreas. In the middle picture is a CT which shows dense pancreatic calcifications. You can see them here. And on the right, an endoscopic ultrasound which shows a calcification with an acoustic shadow here, which is also consistent with a calcified stone. So these are very specific. These findings of diffuse calcification are very specific for chronic pancreatitis. The problem is that they take many, many years to develop. And so that if you were to do a CT scan, let's say 10 years earlier in this patient in the middle, even though they have maybe chronic abdominal pain and progressive chronic pancreatitis, they might not have had the disease long enough at that point to have developed calcifications. So calcifications are quite specific, but they're not at all sensitive. And that's one of the challenges in this condition, is trying to make a diagnosis early on before the disease is sort of burned out like it is in these patients, and at a time where you might actually be able to intervene in some way. So what are the other options to try to make a diagnosis a little bit earlier? Well, MRI has become probably a much more widely used technique. And MRI can look at the substance of the pancreas, the gland itself, using T1 signaling and various other metrics that can be quite helpful in looking for evidence of inflammation or fibrosis. MRI can also obviously look at the pancreatic duct itself with the MRCP technique. Here in this patient on the left is sort of a dilated pancreatic duct, which is quite abnormal, sort of consistent with chronic pancreatitis. And you can even sort of qualitatively assess pancreatic function. This picture on the right, where the hormone secretin has been administered, and as that's been administered, the pancreas secretes bicarbonate-rich fluid, and what you see is this white fluid filling the duodenum here, and you can sort of estimate, pardon me, pancreatic secretory capacity by that technique. So MRIs become very widely used. Now another A technique that's becoming much more widely used is endoscopic ultrasound, which gives you very detailed images of the pancreas. Here in this patient on the left, sort of an irregular pancreatic duct, which is this stripe right through here, this darker tube, and some what are called hyperechoic strands in the substance of the pancreas. Here the pancreas as well with these so-called hyperechoic foci and strands. And here's something called lobularity, which is where you see almost like this sort of honeycomb structure. And what's listed below, pardon me, in bold, one more sip of water, sorry. It says how many features, and what that's referring to are different ways to gauge how abnormal the EUS is. And the mechanism or the nomenclature that's used most commonly is what's called minimal standard terminology. And there are 9 features in this format. And so the score can be 0 to 9, depending on the number. And sorry, I'm having this weird little cough. But anyway, in this scoring system between 0 and 9, normally EUS is classified as 0, 1, or 2 features. A very abnormal EUS is classified as 5 or more, but the area in the middle, the 3 to 4 criteria, is sort of a gray area. It's listed as indeterminate. And the reason it's indeterminate is you can see similar changes in the pancreas in lots of patients that don't actually have chronic pancreatitis, like elderly patients, or patients who are long-standing diabetics, patients who are social drinkers or social smokers, patients that are obese, and a variety of other conditions. And this has been termed sort of a pancreatopathy, if you will. It's injury to the pancreas, maybe the consequences, the normal wear and tear of living, but not really chronic pancreatitis. And it's one of the challenges of EUS, and I think of sometimes other diagnostic tests which try to identify these patients with earlier chronic pancreatitis, is there's a wide spectrum of findings you can see that don't always clarify whether they actually have chronic pancreatitis. So we still are searching for a diagnostic test that can reliably identify patients early in the disease course. Now, the other list of tests that I mentioned are tests which try to assess pancreatic function. The one at the top is the Secretin Test, and in the traditional way that it's done, a tube's put down into the duodenum. You administer a supraphysiologic dose of the hormone secretin, and you collect the fluid that comes out of the pancreas. And primarily what you measure is the bicarbonate concentrations, and you can distinguish normal from chronic pancreatitis. And this test, although it does seem to be best able to identify patients early in the clinical course, it's not widely used because of the difficulty of getting patients to tolerate that tube, which is placed without anesthesia. So there is a substitute. It's where you give the same hormone secretin, but instead you sedate the patient and you put an endoscope down and you can collect pancreatic juice. And here you can see pancreatic juice coming out of, in this case, the minor papilla, but it can be the major papilla as well. And through the scope, you can collect this fluid and analyze it for bicarbonate concentration. Still a bit of a laborious test, but something that can be used and can be useful in patients in whom you're not quite sure if they have early chronic pancreatitis or some other cause of, let's say, a chronic abdominal pain syndrome. So the last part of my talk is just going to be thinking a little bit about treatment of these patients. And I mentioned that pain is the most common symptom, which we'll focus a little bit on, and I'll talk briefly about exocrine insufficiency and endocrine insufficiency as well. So first for pain, there's a menu of options that are available to treat these patients, and unfortunately, none of these options are highly effective. We have medical therapy, and I'll briefly review that on the next slide. These are only of moderate effectiveness. Endoscopic therapy can be employed for specific patients with specific pancreatic ductal anatomy, but not for all patients. Neurolysis, that is a celiac plexus block, is sometimes considered in patients that have intractable symptoms. And then there are surgical therapies as well. First, for medical therapy, I mentioned that not all chronic pancreatitis is alcohol and tobacco, but some of it is. And in patients that smoke or drink, inducing abstinence is beneficial. It reduces the progress of the disease. It reduces their future risk of pancreatic cancer, and it often has a beneficial effect on pain, although the magnitude of the pain reduction is unpredictable. We do have randomized controlled trial data that says some lower potency narcotics like tramadol can be useful, and this is a good place to start in patients that require opioids. We do have some randomized controlled trial data that adjunctive agents, in particular the gabapentoids, Lyrica or gabapentin, can be effective. And although we don't have clinical trial data, certainly tricyclics and SSRIs are used equally commonly, I think, as adjunctive agents in patients that have severe enough pain that they require opioids. Discussion over the years about whether pancreatic enzymes are useful for pain. The bottom line is we don't have a lot of good data that supports their use. We do have some randomized trials on antioxidants. Unfortunately, the data is mixed. One large trial said they work relatively well, and one large trial said they don't work at all. And we don't have a lot of data on some of the non-traditional therapies, although my patients ask a lot about this, like cognitive behavioral therapy or acupuncture, acupressure, mindfulness, meditation, CBD oil, medical marijuana, etc. So I think many patients end up trying these because the medical therapies that we have are often not sufficiently effective. So most patients get tried on medical therapy. Some patients get endoscopic therapy as well. To provide endoscopic therapy, you need both an appropriate pancreatic ductal anatomy as well as the endoscopic expertise. And generally, the patients that are most amenable to this type of intervention are those that have an obstruction in the head of the pancreas with upstream dilation of the pancreatic duct. And the obstruction is either a stone or a stricture, and there are a variety of techniques that can be used to deal with that. I will make one point though, and that is that the patient's symptoms, that is the severity of the pain, and the CAT scan or the ERCP don't correlate. And by that I mean you'll see patients who have many, a large dilated pancreatic duct due to a stenosis in the head of the pancreas who have no pain. And you'll see patients who have a non-dilated pancreatic duct and no calcifications who have terrible pain. So just as a sort of a clinical pearl, what the CAT scan looks like and what the patient feels are often very different experiences. Next, a little bit about surgical therapy. So the surgical therapies largely are employed in patients who have pancreatic ductal anatomy, which is might also allow endoscopic therapy. So they tend to be patients with a dilated pancreatic duct, just because that's a lot easier to find for the surgeon. The sort of classic operation is on the right. It's called a Pusteaux operation, and here the pancreatic duct is incised longitudinally, and then any strictures are incised and stones are removed, and then it's overlaid with a defunctionalized roux limb. And on the left is a sort of a variation of that, the so-called Fry operation, where in addition to the duct being filleted open, a portion of the pancreatic head has been sort of cored out here. And then again, it's overlaid with a defunctionalized roux limb. We are starting to get a little bit of more clinical data on the value and role of surgical therapy in chronic pancreatitis. We know that the Pusteaux procedure is actually fairly effective if you have carefully selected patients, but that over time the pain relief drops off, and these are sort of averages. Immediate pain relief in maybe 80%, but it drops to half that over long-term follow-up. And then we have these procedures that combine resection with drainage. I mentioned the Fry. there are others as well, which I just mentioned here. But these resection procedures are not done as commonly in the US because fewer surgeons are trained in them. They seem to do about the same immediately, but they have better long-term pain relief, but the price you pay is higher morbidity. And then there's total pancreatectomy with transplanted islet cells here. The gland is removed entirely. The gland is digested. The islets are harvested and injected back into the portal vein with a plan to both reduce the pain, but also to prevent the subsequent diabetes of total pancreatectomy. So this is something that's used, I think, much more commonly in children than adults, but is occasionally recommended in patients with sort of intractable symptoms. I will make just one point about surgery and endoscopy. We now have some randomized trials that show that surgical therapy for pain and chronic pancreatitis is a little bit more effective and it's more durable than endoscopic therapy. And in a very recent randomized trial that suggests that earlier surgical intervention is more beneficial in terms of pain relief than later surgical intervention. So this of evolving research interest. So let's leave pain and talk a little bit about exocrine insufficiency. Again, these are patients who generally have less than 10% of normal enzyme output. They oftentimes get steatorrhea, that is fat in stools, but interestingly, they may not always have diarrhea. So they may have massive steatorrhea without complaints of diarrhea. They lose weight, they lose muscle mass, sarcopenia, and this does create problems in managing diabetes because you can't predict nutrient absorption very well. They get osteopenia and osteoporosis in very high proportions, and they have a significant risk of bone fracture. And they can get specific vitamin, mineral, or micronutrient deficiency. Largely, these are fat-soluble vitamins, but everything can be seen. On the right is a patient of mine who allowed me to take his picture, who has had surgery for chronic pancreatitis, and the rash you see there is pellagra, a niacin deficiency in a patient with chronic pancreatitis and exocrine insufficiency. And there's clear data that once patients get exocrine insufficiency, they have increased mortality, whether the exocrine insufficiency is due to chronic pancreatitis or whether the exocrine insufficiency, as it often is, also due to pancreatic ductal adenocarcinoma, which is the subject of another talk. So this is common, although it's generally something that occurs late in the clinical course. How do you treat it? Well, the estimates are that you need about 10% of normal pancreas output per meal to achieve normal digestion and absorption. So normal is about 900,000 USP units. 10% of that is 90,000. You may still have some pancreas which is making enzymes, and there is a gastric lipase that can partially compensate, but nonetheless, the minimal starting dose should be in the 40 to 50 to 60,000 with each meal, and half that with snacks. Make sure they take it during the meal, that is while they're eating the meal. And you can weight base it either for pediatrics or very small adults, but generally 40 to 60,000 is a reasonable starting point. And because of this risk of fat-soluble vitamin deficiency and osteoporosis, you should just keep in the back of your mind that you should be both checking those levels and supplementing those vitamin levels as necessary. This is just a list of the currently available enzyme products. 4 of those are enteric coated. 1 is non-enteric coated. If you're on the non-enteric coated, you have to co-treat them with something to reduce gastric acid, or the lipase will be inactivated by gastric lipase. And you can see the various strength of the products that are available. Again, you should be aiming at a starting dose that they're getting somewhere in the 40 to 60,000 at a minimum. We've studied this, at least in the US, only about 1 in 10 patients with chronic pancreatitis get prescribed the right dose when they're prescribed pancreatic enzyme replacement therapy. So there's a lot of misunderstanding about how much and when to give these drugs in many countries, including the US. I mentioned the endocrine insufficiency, this curious type of diabetes called type 3C. And in these patients, the entire islet is lost. So they lose insulin, but they also lose the other counter-regulatory hormones like glucagon. And what it means is that if they're over-treated and they drop their blood sugar, they don't have a glucagon surge to push the blood sugar back up, so they can't rescue themselves as easily from hypoglycemia, and they get often serious complications of treatment-induced hypoglycemia. And interestingly enough, when patients with chronic pancreatitis develop this type of diabetes, the risk of subsequent pancreatic cancer goes up dramatically. And so the reason for that is unclear, but it's an area of current study. And then finally, just to mention that there are other complications, and the one that a lot of patients are worried about is pancreatic cancer, and there is an excess risk of pancreatic cancer. This excess risk is largely in those that continue to smoke. So if you can get patients to stop smoking, that will significantly improve their chances of avoiding pancreatic cancer. And there are some ones that I mentioned here just for completeness, but I won't really be talking about. So that's just a very brief review of chronic pancreatitis in adults. I don't believe we're going to take questions now, although you will see that this manatee is wearing a mask and is avoiding COVID as he's supposed to, even though he's in Florida. So I'll finish there and then turn it over to Mark to take the next step.